Okay, and now I would like to introduce Dr. Middleton. Dr. Addie Middleton is a physical therapist and researcher who's currently at the New England Geriatric Research Education and Clinical Center at the VA in Boston. Addie and I first met through our mutual interest in physical therapy-related health services research and the Center on Health Services Training and Research, which is funded by the American Physical Therapy Association. However, her interest in quantitative analysis comes from her experience receiving a BA in economics with a minor in mathematical science at the University of North Carolina. She then went on to receive her clinical doctorate in physical therapy and a PhD in rehabilitation science at the University of South Carolina, with a few years of practicing in between. She completed her health services research postdoctoral fellowship in the Division of Rehabilitation Sciences at the University of Texas Medical Branch under the mentorship of Dr. Kenneth Ottenbacher, which I know many of our health services researchers here are familiar with that program. And she supplemented this training with a 2-year faculty fellowship in implementation science at the Center of Excellence in Physical Therapy Health Services and Health Policy Training. She previously worked on faculty at the Medical University of South Carolina before transitioning recently to the VA. Without further ado, I would like to pass it off to Dr. Middleton to begin her talk on post-acute rehabilitation using research to influence federal health policy. Thank you.
Thank you, Dr. Rafferty, and thank you all. I am really excited about the opportunity to be part of your research seminar series. I wish I could be there in person, but I'm glad that we have this virtual option. So today I'm going to talk a little bit about my work in the area of post-acute rehabilitation, some of my health services research work that was very much influenced by some ongoing healthcare reforms. And also this is work that was motivated by my and my colleagues' interest in identifying or addressing some gaps in the evidence related to these healthcare reforms. So I'm going to start with a little bit of context because context is key. So Dr. Rafferty did a great job introducing me, but I will provide just a little more information on my background for that personal context. And then I'll provide a little bit of background information on the healthcare reform and policy, and particularly the legislation that influenced the work I'm going to talk about. I'll then move into the research portion of my talk, where I'm going to go through 3 projects related to healthcare reform and policy. And I've picked projects that were in the area of inpatient rehabilitation because I thought that that might be of most interest to this audience of all the post-acute settings. I thought inpatient rehabilitation was probably the most relevant. And then I'll finish up with time for questions and discussion. But as I told Dr. Rafferty before we began this, I am open to questions during the talk if there's any clarifying points or any questions that would be best answered during my talk. So feel free to put those in the chat. So starting with a little bit more about me, as Dr. Rafferty mentioned, I went to the University of North Carolina for undergrad, where I majored in economics and minored in mathematical sciences. So even as an 18-year-old, I had an interest in looking at things from a big picture perspective. However, my dream job was to be a physical therapist. So I went to grad school, got my DPT, and then I worked clinically for about 4 to 5 years. And it was really my clinical experiences that drove my interest in transitioning into a more research-related career, but also very much influenced my research interest. So I worked in both acute and post-acute care settings. And in both of those settings, there were frequent flyers. So individuals that would cycle through the continuum repeatedly. And every time they came through, they were a little worse than the time before. And I became very interested in how we could improve things and try to break that cycle. And that's shaped the research that I'm going to talk about, as well as some of my current research in my new position. So after working for about 5 years, I decided I wanted to get more involved in research. I went back to the University of South Carolina for my PhD, and then did a postdoctoral fellowship in health services research with Dr. Ken Ottenbacher. I then transitioned into a faculty position in the Doctor of Physical Therapy program at MUSC. But due to my research interest and long-term career goals, I transitioned recently into a position with the New England Geriatric Research and Education Clinical Center, or the GREC, within VA Boston Healthcare System. Because that's fairly recent, the work I'm going to talk about was work I conducted while at UTMB and MUSC. However, the research that I'm starting now builds on this work. So moving on to a little bit of background on healthcare reform and policy. And I'm going to try to not get too in the weeds here and don't want to bore you to death, but I do want to provide a little bit of context. So there's been a string of legislation dating all the way back to the Social Security Act in 1935 that has really led to this transformation in our healthcare system, to this delivery system reform, where we've shifted from a healthcare system that rewards the volume of services provided, so that fee-for-service system, to one that rewards the value of those services. And I think this is really seen in some of the more recent legislation, such as the Affordable Care Act, which probably most of us are familiar with, and the Impact Act. And if you're not familiar with the Impact Act was passed in 2014, and it's the Improving Medicare Post-Acute Care Transformation Act. So as I mentioned, there's been this shift from a healthcare system that rewards volume to one that rewards value. And this is really seen in some of the programs that came out of the Affordable Care Act that are focused on quality and value, including some programs specific to post-acute care. So the Inpatient Rehabilitation Facility Quality Reporting Program, as well as the Long-Term Care Hospital Quality Reporting Program, came out of this act. And then the Skilled Nursing Facility Value-Based Purchasing Program. So even back in 2010, things were starting to focus on post-acute care. Post-acute care became an even bigger focus of reform with the passing of the Impact Act. And one of the things mandated in the Impact Act was the development of standardized measures, standardized quality and efficiency measures for post-acute care. And these measures were to be developed in a variety of areas, and I've listed those areas here on this screen. And you can see they range from skin integrity to med reconciliation, falls, and even include some resource use measures. So really capturing the broad spectrum. And some of these areas aligned with what drove me to leave clinical practice and come to the research side, such as functional status, discharge to community, and potentially preventable readmissions. So the Impact Act mandated the development of these quality measures, but there's a process that has to occur in order for measures to go from development into being used in the Medicare program. There's a pre-rulemaking process, and this is something that came out of the Affordable Care Act. But every year, CMS has to make publicly available a list of the measures that are under consideration for the Medicare program. So measures that are related to quality and efficiency. And in 2015, many of the measures on this list were related to post-acute care. This is coming right on the heels of the Impact Act, which, remember, mandated the development of these standardized quality measures. So the list of measures under consideration for 2015 included many measures related to post-acute care. And on this slide, I show some of the different post-acute care programs, so the quality reporting and value-based purchasing programs. And then the number in parentheses is the number of measures under consideration for that program. So these were the number of measures on that 2015 list of measures under consideration. So for example, there were 5 measures under consideration at that time for the Inpatient Rehabilitation Facility Quality Reporting Program. And that list of measures under consideration and the Impact Act and the move towards really focusing on post-acute care influenced the research that I started. So this is right when I was starting my postdoc at UTMB, and that list very much influenced the next couple projects that I worked on. Which brings me to the research portion of my talk. So the first project I'm going to talk about focused on potentially preventable within-stay readmissions. This was one of the measures on that list of measures under consideration, so it's not yet a quality measure, but it is being considered developed for the Inpatient Rehabilitation Facility Quality Reporting Program. And there's two important things to keep in mind when I'm talking about these within-stay readmissions. The first is the timing. So for the quality measure, potentially preventable within-stay readmissions are those that occur during the inpatient rehabilitation stay or the day after discharge. And I think the rationale here is that readmissions occurring the day after discharge are more likely related to the care the patient received while they were in the facility versus an issue with transitional care or follow-up care. So just keep in mind that within stay is referring to during the stay or the day after discharge. And these also include temporary transfers back to acute care. So what in inpatient rehabilitation we usually refer to as a program interruption, the within stay measure included program interruptions if they were potentially preventable. Which brings me to the next thing to keep in mind. So for this quality measure, a specific unique list of conditions was developed, and these were conditions that are considered to be potentially preventable with appropriate medical monitoring and medical management. So they should be preventable while the patient is there receiving care in the facility. And the conditions, diagnoses included on this list fell into 5 broad categories. So they were conditions related to inadequate management of chronic conditions, inadequate management of infections, inadequate management of unplanned events, inadequate prophylaxis, and inadequate injury prevention. For this project, we had 2 pretty simple, straightforward objectives. The first was to look at patient-level predictors of these potentially preventable within-stay readmissions. The second objective was to look at the medical diagnoses leading to those potentially preventable readmissions. So we were interested in who was at risk and what were they at risk for. Here's our cohort selection. I wanted to present it so that you can see it, but I'm not going to go through it step by step. I'll just hit some of the highlights. We started with a cohort of about 506,000 Medicare fee-for-service beneficiaries who were admitted to inpatient rehabilitation between August 1st, 2012 and November 15th, 2013. For all the projects I'm going to talk about today, all 3 projects, we were using 100% Medicare files, and I'm more than happy to talk about the different files we used with anyone who's interested. For this project, we were interested in those individuals who were receiving post-acute care, who were transferring basically straight from the hospital to inpatient rehabilitation. We also, for this project, for these within-stay readmissions, excluded individuals who had atypical lengths of stay in the inpatient rehab facility or in acute care, just because we thought that these individuals were not representative of typical patients, typical post-acute patients, and had some medical complexities that were, may make them at higher risk for these within-stay readmissions that may just atypical, so we removed those patients. Our final cohort included about 346,000 Medicare fee-for-service beneficiaries who were admitted to inpatient rehabilitation. The average age of the cohort was 76, about 59% were female, and about 82% non-Hispanic white. The overall rate of potentially preventable within-stay readmissions over the study window was 3.5%. So about 12,000 individuals experienced a potentially preventable within-stay readmission. When we looked at patient characteristics, unsurprisingly, we saw that patients who had more prior hospitalizations over that 6-month window before their index hospitalization. So there was a 6-month window, then they were admitted to the hospital for what we considered their index hospitalization, and then they were admitted to inpatient rehabilitation. So those who had had more hospitalizations over that 6-month look-back window had higher rates and odds of a potentially preventable within-stay readmission, as did those who were in the hospital, had a longer length of stay in the hospital right before rehab, those who were in the ICU right before rehab, and those with more comorbidities. Function was one of our predictors of interest. And what we found was that individuals who were more independent at admission, this is based on FIM scores, so those who basically had higher FIM scores at admission, had lower rates and odds of a potentially preventable within-stay readmission. And this was seen across all three domains of self-care, mobility, and cognition. Regarding reasons patients were experiencing these within-stay readmissions, about 37% were for inadequate management of infection, 27% for inadequate management of other unplanned events, and about 23% for inadequate management of chronic conditions. Diagnoses related to inadequate prophylaxis and inadequate injury prevention were observed less frequently. And I want to acknowledge that one of my colleagues, collaborators on this project is Ann Deutsch, who is on this call. So thank you for contributing to this project. So those were within-stay readmissions. The next project I'm going to talk about are 30-day post-discharge, potentially preventable readmissions. Again, this is one of the measures that was under consideration at the time for the Inpatient Rehabilitation Facility Quality Reporting Program, and it was one of the measures mandated by the IMPACT Act. For this measure, the window to look for readmissions is day 2 to 32 after discharge. So it does not include the day after discharge. There's no overlap between these two quality measures. The within stay is during care or the day after discharge, and then the post-discharge readmission measure picks up and goes from day 2 to 32. As with the within stay measure, a unique list of conditions was developed. So these are diagnoses, conditions that are considered potentially preventable with appropriate transitional and follow-up care. Unlike the within stay measure, it does not include any conditions related to inadequate prophylaxis or inadequate injury prevention. For this project, we really focused in on function. So we were interested in the degree to which individuals' functional status at discharge was associated with 30-day potentially preventable rehospitalizations. Again, I'm showing the full cohort selection, but I will just hit the highlights. For this project, we started with a cohort of about 737,000 Medicare fee-for-service beneficiaries who were discharged from inpatient rehabilitation in 2013 through October 30th of 2014. As with the within stay project, we were most interested in those who were coming to inpatient rehab pretty much straight from the hospital. So really true post-acute care. And our final cohort included about 372,000 Medicare fee-for-service beneficiaries. The average age of this cohort was 79. About 60% were female and about 85% non-Hispanic white. Overall, the rate of 30-day readmissions, and this is a readmission for any reason, was 12.4%. The overall rate of potentially preventable readmissions over that same window was 5%. And I'm not trying to be tricky with numbers, but what this indicates is that 40% of all readmissions over that 30-day window were for a condition considered potentially preventable. Our predictor of interest was function. And what we found was that patients who were more functionally independent at discharge, so again, this is based on FIM, those who were more independent, had lower odds of a 30-day potentially preventable readmission. And this was, again, seen over all three domains, self-care, mobility, and cognition. Regarding reasons, about 44% of these potentially preventable readmissions were for conditions related to inadequate management of infection, about 31% for conditions related to inadequate management of chronic conditions, and about 25% for inadequate management of other unplanned events. And on the slide, I also included the specific diagnoses, so you get a better feel for what conditions these patients were experiencing. So we see that under the category of inadequate management of infection, septicemia, UTI, pneumonia were all common conditions. Under the category of inadequate management of chronic conditions, heart failure was fairly common. And then in the category of inadequate management of other unplanned events, kidney failure and AFib were fairly common. So those were the two projects we conducted focused on potentially preventable readmissions. Sort of along those same lines, we were also interested in successful community discharge. Again, this was one of the measures under consideration for the Inpatient Rehabilitation Facility Quality Reporting Program. And it was also one of the measures mandated by the IMPACT Act. So for the quality measure, successful community discharge is operationally defined as discharging to the community and not experiencing an unplanned hospitalization or death over the next 31 days. For this project, we were interested in whether or not rates of successful community discharge varied across facilities or across geographic regions. So here we were focusing on variation in this quality measure. Here's our cohort selection, and it's set up a little differently because we were evolving and our cohort selection figures are getting better. So for this project, we started with a cohort of about 707,000 Medicare fee-for-service beneficiaries discharged from inpatient rehabilitation in 2014 through October 1st, 2015. For this project, because we were looking at variation in the quality measure, we wanted to be sure that we replicated the actual quality measure as closely as possible. And this is a few years out from that measures under consideration list being published. There's more out there on this, more specifications. So we were able to more closely replicate the quality measure. So we applied the specific selection criteria from the quality measure to identify our cohort. So I want to point out a few differences from the prior projects. So the first is that for the quality measure, patients don't have to be coming straight to inpatient rehab from the hospital. So before we were looking at those almost direct transfers, patients who were within a day of their hospital discharge. Here for this quality measure, it's just that they had to have a hospital stay over the 30 days prior to their inpatient rehab admission. Then we applied the other selection criteria and ended up with a cohort of about 488,000 Medicare fee-for-service beneficiaries who met the selection criteria. So we had our cohort. We then tried to replicate the data analyses as closely as possible as well. So we calculated risk-standardized successful community discharge rates for all inpatient rehab facilities submitting claims to CMS over the study period. So this was 1,154 facilities. And then we calculated 95% confidence intervals for those risk-standardized rates. So every facility had a successful community discharge rate and a 95% confidence interval. We then repeated that process at the state level to take a kind of crude look at geographic variation. So starting with what we found at the facility level. I'm gonna take a minute to just orient you to this figure. I guess let's start with the black line across the center of the figure. this is the overall rate. So across all 1,154 inpatient rehab facilities, the overall rate of successful community discharge was 63.7%. As I mentioned on the prior slide, we calculated the risk standardized successful community discharge rate for each facility. We then use those rates to rank facilities from the lowest performing, so the facility with the lowest rate of successful community discharges, to the highest performing, the facility with the highest rate of successful community discharges. And then we plotted them. So the x-axis is the facility ranking. So it goes from 1 to 1,154. And then the y-axis is the risk standardized rate of successful community discharges. The shadowy line that sort of snakes across the figure are the actual individual rates. So there's a dot for each facility, and because they're plotted in rank order, the dots touch and it looks like a line, but it's actually individual dots representing each facility's rate of successful community discharges. And then the vertical lines that give the graph kind of a fuzzy appearance, the colorful lines, are the 95% confidence intervals. The 95% confidence intervals shown in red represent facilities that are performing significantly worse than average. And the 95% confidence intervals shown in green represent facilities performing significantly better than average. So we see that about 18% of facilities were performing significantly worse than average and about 19% better than average. So there is variation. And what this suggests is that there's opportunities for improvement. So a potentially important area for future work might be to better understand what's going on at the high and low performing facilities and what information we can use to improve the process, improve successful community discharges across the board. We also looked at geographic variation, and as I mentioned, this was kind of a very crude look at geographic variation because we did it at the state level. However, I think an interesting finding was that there is sort of regional variation. There are certain areas of the country with higher rates and certain areas of the country with lower rates. Again, suggesting that potentially future research should sort of dive into this to see what's going on in these areas with high rates of successful community discharge, what's promoting these successful community discharges, and what's going on in the areas with low rates, what's hindering these successful community discharges, and how can we use that to improve the process. So there are some limitations of all of the projects that I just presented. We use administrative data for all of those projects. This is data that's collected for claims and billing purposes. It is not collected for research purposes. It's entered by different people all over the country. And so there's always questions or concerns about the accuracy of that data. There's also limitations related to the information that's available in those sorts of data sets. For example, and very relevant to the projects I talked about, there isn't a whole lot of detailed information on social support. And social support could play a pretty big role in successful community discharges and those post-discharge potentially preventable readmissions. So there's some lack or some limitation in the information that's available. Also, all three projects were observational study designs, and there's definitely limitations inherent in those type of study designs. The findings from all three projects are most generalizable to Medicare fee-for-service beneficiaries and may not be applicable to individuals with different payer sources. And then the last thing I have listed on this slide is kind of a limitation, but maybe more of a consideration. For all of these projects, we defined our outcome using the definition used in the quality measure. So we defined potentially preventable readmissions using the specific list of diagnoses included in the quality measure. And we defined successful community discharges using that operational definition of a successful community discharge. Not everyone may agree that the diagnoses on the potentially preventable readmission list are truly potentially preventable. And some people may have different ideas about what a successful community discharge looks like. So as I said, not necessarily a limitation, but certainly a consideration and something that I wanted to acknowledge. Despite the limitations, I do think that these projects did contribute to an area where there was not a lot out there, so to a gap in the evidence. We provided insight into these measures under consideration, these new quality measures, looked at some information on the patient characteristics associated with them, the fact that function matters, which I think is always important to get out in the literature, and then also that there's some variation in the successful community discharge ones, so potentially opportunities for improvement. Also, because this was a fairly new area and there wasn't a lot out there, we provide some baseline information. So moving forward, as future reforms are implemented, as policy changes, it provides kind of a starting point or something we can look back at to see how things change. You know, are things improving, or are there any unintended consequences? So I just spent some time focusing in on very specific projects, but I want to step back again and look at the big picture. In healthcare, providers practice, deliver services in ways to impact patients' outcomes. That's the goal of healthcare practice, is to impact outcomes, to help our patients. In an ideal world, the way we practice clinical decision-making is based on the practitioner's expertise, the patient in front of them. So what is that patient? What are their preferences and expectations? And then hopefully it's also guided by the best available evidence relevant to that patient. This is really just the definition of evidence-based practice. As I mentioned, that's the ideal world. In reality, healthcare practice is very much influenced by policy. And I know from my own experiences, when I'm working with a patient, if they have a limitation on visits or some sort of cap, it's going to impact my plan of care and how I move forward with that patient to best meet their needs while delivering care within the restraints of policy. Where health services research fits into this is it takes information from real-world practice and outcomes and generates evidence that can influence policy. So typically the way this works, this is a really simplified version of this, is policymakers, so legislators, CMS, work with groups. These can be contract companies, so RTI, which I'm sure many of you are familiar with, RAND, Mathematica, those type companies will have contracts and do projects and develop documents for these individuals who are driving policy. And then there's other groups like MedPAC, so the Medicare Payment Advisory Commission, that also generates documents. So different groups generate documents, reports that are then used and influence policy. And the individuals developing these documents really rely on the literature. They go to the literature to find references to inform their recommendations, really to support their recommendations, or in some cases to support concerns. So they're using the literature. They may be conducting a project. There's still a lot of a literature review that goes on and a use of the evidence that's out there. And so to give you some specific examples now that I've talked about this work, the line of research that I presented related to inpatient rehabilitation facility with in-stay readmissions, there was more than one paper that came out of this line of research. One of them was referenced in the final specifications for the inpatient rehabilitation facility quality reporting program and standardized patient assessment data elements. This was a report prepared for CMS by RTI and RAND. And then the line of research related to potentially preventable post-discharge readmissions was referenced in the March 2019 MedPAC report. And I wish, so full disclosure, I wish I could say that these references were used in a really impactful way and were policy shifting. They weren't, but they were used. They helped inform. So, and this document, the one on the IRF quality reporting program, this reference was used to support a recommendation for one of the standardized patient assessment data elements. And then in the MedPAC report, this work was used actually to support a concern. So MedPAC was saying that there were concerns with provider reported quality measures and that it may be more appropriate to focus on claims-based quality measures. And so this work was supporting the claims-based side of that. So the literature is used. It's used by these groups who are creating documents that influence policy. So it brings me to kind of my take-home message. It's really important that rehab professionals, the rehab field, are contributing to this body of knowledge that's guiding policy. And if you're interested, some ways that you could contribute are to just stay informed, not just what's happening now. I think there's a lot happening in healthcare right now, and it's easy to focus on that, but it may be more important to focus on what's next. So what's in the pipeline? What are the priority areas? What does the future look like? And how could I help provide evidence that could guide that future, shape that future? And so at first, it may not seem like your area of work really aligns with that, but I think if you step back and think about the big picture, so the really big picture and even the trickle-down effects and everybody that's going to be impacted by something and how you could help inform one of those littler pieces. So how does your work align with something that will be impacted by future reform or policy? So really, the take-home is that it's kind of a call to action that the rehab field needs to be involved in generating the evidence that's going to be used to guide policy because it's incredibly important that we have a voice. And with that, I would like to thank the people mostly at UTMB, so Dr. Ken Attenbacher and James Graham, and the resources that helped support this work. And thank you. I got through that really fast, so probably skipped some important information. So I'm happy to answer any questions.
Thank you, Dr. Middleton. There was some good chat going on in the chat box, and I'll start with the one that was kind of more directly related to your first project, and I'm not sure if the information is available in the data sets that you were using, but is there any difference in readmissions from inpatient, during the inpatient rehabilitation facilities that were in facilities that are located within the acute rehabilitation or within the acute care hospital versus freestanding centers like ours? And I don't know if you would know the answer to that or if the data is available.
The data is certainly available. We didn't look at that, and I'm not sure if someone has in the interim because it has been a while. So I'm not sure. The data is available, and I think that would be important to look at, and maybe with some more recent data.
Mm-hmm. Yeah, that would be really interesting. And just again, to remind everybody, if you are right now one of the participants on the call and you would have questions that you'd like to ask Dr. Middleton directly, please feel free to unmute yourself or turn on your camera. Another question that popped up into the box that kind of had some good discussion about it is where we're ranked in your facility level variation data, and which chimed in with the quality measure data set at medicare.gov. So, and then I admit I got a little bit distracted playing around with see if I could locate us.
I actually had slides with, I was going to have Shirley, all the quality reporting stuff, but that got cut.
Well, if you have it on your computer, I feel like there could be some interest in seeing it because, I just looked at it. Thanks, Dr. Lee. Yeah, if there's, I was really interested because it's kind of like on some things where I just pulled us up and compared it to two other Chicago area rehab facilities, one that is freestanding and one that is located kind of, it's technically a separate building, but kind of connected quarters to the acute care setting. And I mean, first of all, I'm struck by the fact that some of these things are such small events, like rate of pressure ulcers, I'm sorry, my words are not working right now, that are new or worsened, and it's, 0.3, 0.4, 0.7. And there, the two freestanding hospitals are actually better than the connected one for their rate, as well as better than the national average. The national average is 0.6. So it's really, in some ways, such a small difference for some of these things.
And that's one of the reasons we were interested in looking at variation, because if rates are low and there's not a lot of variation, there really isn't, potentially there's not room to move the needle. And so when we got to that successful community discharge one, we were really interested in, how much variation was there? Was this something we could really improve?
And you kind of mentioned that one of the future ways to do this could be looking at some of those high performers and low performers and trying to figure out what they're doing differently. Do you think that the difference between them is really like a clinically meaningful difference? And what would be the best way to try to separate out, like are you thinking it would be a qualitative study, or do you think you could do it numerically through the data?
I personally, this is, just opinion here, think that at this point we may need to move into qualitative. I think it's stuff we're not capturing in the data, because there may be things going on in those programs or in those facilities, different programs or things that are leading to better outcomes. So I think that this would be more at this point kind of a qualitative, looking at the really high performers, really low performers, to see what's happening in those facilities and if there's something that's not being caught in these data sets that could help inform improvements.
Yeah, great, thank you. And for that, to that specific question on, what just disappeared from my computer, of percent of successful return to home and community, the national average was 65.42%, and our Shirley Ryan Ability Lab is rated as worse than the national rate. But that was clear on your slide with the, when you showed the different regions. Could you bring that slide up again? I thought that was interesting, because we are, where we are very similar also to the Northeast, and the regional rate is 59.3%. So although the website doesn't give the actual rate for Shirley Ryan Ability Lab, it says that we're below the national average, which was 65%, and here the Illinois area is at 59%. So hopefully we're at least regionally similar, if not worse. But Dr. Harvey made a very good point in the chat box that we take care of very complex patients compared to a typical community inpatient rehabilitation facility. And you mentioned some of your case mix adjustment, but how much do those case mix adjustments like the Elix Hauser really control for the complexity of the patients?
Well, and so, yeah, we use the Elix Hauser in those early potentially preventable ones, and the quality measures, they use different ways to look at comorbidities and all. But I still think, I agree, that there are complexity issues that aren't always caught with the risk adjustment. And I know that measure developers work really hard to make it, fair and to adjust, but there's just some stuff that isn't captured. And I mean, this is me being a PT, but function matters so much. And, we don't have, I think that having better measures of function would also be something we'd want to consider. But yeah, the things like the Elix Hauser and all are not the best, but they do a better job in most of the quality measures, and that's what we replicated in the successful community discharge one.
Okay, thank you. Dr. Cotton, James, you asked, could you comment on things like readmission metrics falling afoul of Campbell's law, where the metric ceases to be useful once it is a performance target? It seems like the jury is definitely still out on the congestive heart failure 30-day readmission rates. To Dr. Harvey's point, that could create a negative negative pressure against taking more complex or risky patients.
Yeah.
Yeah, so, and James, if I misstated something or if you have a more clarification of the question, please feel free to discuss.
And so I don't know if we're getting at there's like cherry picking or what they call lemon dropping, like, so being more selective in the patients you take. And I mean, that's the thing with any of these like reforms or quality measures, that people adjust how they practice. And that was one of the issues where I was talking about the provider reported versus the claims based. They're finding that providers are just changing the way they code things to make it look better. So I do think that with anything, if you put it out there as a quality measure, then people are going to figure out how to game the system and make that number better. And it may not actually be reflective of changes in quality and changes in care that are benefiting patients.
That's interesting. I'd heard cherry picking before, but not lemon dropping. But I do like that. But the term makes sense. Great. And then I was wondering if in your research or just in kind of your really in-depth dive into this topic, whether you have any thoughts, research-based or not, or more anecdotal, on why there is the regional discrepancies, particularly, are my interest in like the Midwest and the Northeast and why they're so different from the West Coast.
I don't. I would really like to understand that better. And I was thinking when we started this project that the state level wasn't going to be that informative, that we really needed to drill down deeper. But then looking at the state stuff, I'm like, why? Is it cultural? Is it climate? What is going on that? And I know with the successful community discharge, some of it is Medicaid related. So I really think that Medicaid programs differ by states, and they play a big role in like those long-term services and supports. And some places just have a better community setup for services and supports, and potentially it's things like that are driving it. So just Medicaid policy variation, but I don't know. That's purely just a hypothesis.
That would be really interesting to like overlay the Medicaid expansion or like other types of policy related things to the map of quality and inpatient rehab. Great. Well, that is the end of questions so far in the chat box, and kind of summarizing the discussion there. I want to give a minute here to see if anybody else has any thoughts that they want to share or questions for Dr. Middleton. Ann Deutsch does highlight here in the chat that, as you mentioned, research can be used by policymakers to improve risk adjustment models and refinements to the quality measures. So hopefully that might be a call to action to all of the functional researchers on the phone to kind of help come up with ways to measure function that can be applied by policymakers. And we have a number of people that are on the call right now that are looking at different ways to measure function. Kind of, we had the FIM before, then the QI tool, that's what we call it, internally. I think that's, or the CARE tool or QI tool nationally. And we also have a measure that we've been working on, the Ability Quotient.
I would love to hear more about that.
Well, Dr. Harvey is on the call or on the Zoom. I don't know if he can unmute if we put him on the spot at all to share some thoughts. I'm not sure where he is in the building, if he's in a quiet space. Or if he had to jump off.
He sent a chat. He couldn't access the microphone.
Oh. Well. Well, that is too bad. But this would be one of those things that if only we were in person and we had the availability to make the rounds and do the meetings, that we would discuss more. But hopefully, if there's any information that we can share, I'll follow up with you, Addie, and let you know. Definitely, so I think some of the preliminary data is looking interesting, and I know that the organization is hoping that they'll be able to share that metric kind of soon to do some more testing.
say, I know even in my work now, like I'm trying to figure out how to best measure function.
Mm-hmm. And right now, are you working mostly with like your local VA data, or are you working with larger VA data?
So I'm actually not working with data. I'm actually working on a clinical demonstration project. So trying to improve successful community discharge after community living center care, which is the equivalent of a skilled nursing facility. So kind of a mobility care transition type program to improve successful community discharge.
And what things are you using and are they based on the research that you did that was more large data set more, or is it more based on your clinical experience? How are you?
So some of both. It's based on clinical experience, the evidence, most of it's based on evidence and programs. But then just the fact that, and like so much of the work I did at UTMB, that we just kept highlighting that function matters at discharge, and we can identify these people that are at risk and we can help them. We know a modifiable risk factor, potentially function. So how can we use that knowledge to improve outcomes?
Right. Just plugging the role of PT and OT and speech and function. Great. Well, thank you so much. And thank you to all of the listeners. Just a reminder to tune in again next Monday for the Shirley Ryan Ability Research webinar. And I look forward to seeing everybody again then. Thanks, Addie.
Bye, everyone. Thank you.